So welcome to the Kanski lecture series, and this is going to be the chapter 15 Hereditary Fundus Dystrophy part 7, and in this part we are going to discuss about the hereditary vitreoretinopathies. So first we are going to discuss about the juvenile X-linked retinoschisis. So there are two types of retinoschisis. Retinoschisis is basically the separation of the inner layers of the retina, and it can be congenital and it can be acquired. The congenital one is juvenile X-linked retinoschisis, and so let's get started. So and it also affect the nerve fiber layer. The separation is at the nerve fiber layer. Juvenile retinoschisis is characterized by the bilateral maculopathy, which with associated peripheral retinoschisis in 50%. So there is a maculopathy and there is a retinoschisis. The basic defect is mediated by the Muller cells, leading to the split of the retinal nerve fiber layer from the rest of the sensory retina, in contrast to the acquired senile retinoschisis, in which splitting occur at the outer plexiform layer. So in an acquired form, most of the time the splitting occur in outer plexiform layer, but in a cases of a retinoschisis, a juvenile X-linked retinoschisis, the splitting occur at the nerve fiber layer. Inheritance is X-linked recessive, with the implicated gene in most cases designated as retinoschisis associated gene. The prognosis is often poor due to progressive maculopathy. Visual acuity deteriorates during the first 2 decades but may remain reasonably stable until the 5th or 6th decade before further deterioration. Diagnosis: the presentation is usually in boys between the age of 5 and 10 years who are experiencing difficulty with reading. Less frequently, squint or nystagmus occur in infancy associated with advanced peripheral retinoschisis and vitreous hemorrhage. Carrier females are generally asymptomatic. So, as it is an X-linked recessive disease, the boys are usually affected between the age of 5 to 10 years, and they have experienced difficulty in reading. And sometimes squint and nystagmus occur in infancies, that is associated with advanced peripheral retinoschisis and vitreous hemorrhage. Carrier females are asymptomatic. So what are the signs? The most common appearance is a foveal schisis appearing as a spoke-like striae radiating from the foveola, associated with cystoid changes. So there is a foveal schisis, which is like a spoke wheel type appearance radiating from foveola, and there is an associated cystoid changes. Over time, the striae become less evident, leaving a blunted foveal reflex. So we can see 15.40, you can see that a spoke wheel type pattern in the macula. Then whitish drusen's like dot and pigment variation may be seen. The macula is occasionally normal. Peripheral schisis predominantly involve the infratemporal quadrant. So retinoschisis involve the infratemporal quadrant. It often it does not extend, but secondary changes may occur. The inner layer, which consists only of the internal limiting membrane and the retinal nerve fiber layer, may develop oval defect. And in extreme cases, the defect coalesces, leaving only the retinal blood vessels floating in the vitreous veils. So what happens is that the inner layer, which is only consisting of the because there is a separation of the nerve fiber layer, so the only layer that is left is internal limiting membrane and retinal nerve fiber layer. So the oval defects develop, and when the defects coalesces, they leave only the retinal blood vessels floating in the vitreous, which is known as a vitreous veil. So figure 15.740 we show us a large typically oval inner leaf defect. So this is a defect, and you can see the blood vessels floating, and C is showing us an vessels floating, vitreous veils, and D is showing the peripheral dendritic lesions. Silvery peripheral dendritic figures, vascular sheathing and pigmentary changes are common, and retinal flax and nasal dragging of the retinal vessels may be seen. Complications include vitreous and intracaesus hemorrhage, neovascularization, subretinal exudation, and rarely rhegmatogenous or tractional retinal detachment and traumatic rupture of the foveal schisis. So the complications will be the hemorrhage, vitreous hemorrhage, neovascularization, subretinal exudation, rhegmatogenous retinal detachment, tractional retinal detachment, traumatic rupture of the foveal Jesus. Investigation FAF show variable macular abnormalities including spoke-like pattern and central hypo autofluorescence with surrounding hyperautofluorescence. So there will be the macular abnormality which consists of the spoke-like pattern and central. There are going to be the central hypofluorescent and surrounding hyperfluorescent. Then OCT is useful for documenting the maculopathy progression. Cystic spaces in the inner nuclear and outer plexiform layer are commonly present, but the fovea may simply appear disorganized. So let's see figure um, 15.42. So this is a traumatic hole in the macular sheaths. A and B is showing us a separation of the layer of inner layer of retina. So you can see, and there is a cystic spaces. ERG is normal in eyes with isolated maculopathy. Eyes with peripheral sheaths show selective decrease in amplitude of B wave as compared with the A wave on scotopic and photopic testing. So there will be the decrease in B wave. EOG is normal in eyes with isolated maculopathy, but subnormal in eyes with the advanced peripheral lesions. FA of maculopathy may show mild window defect but no leakage in contrast to CMO. So treatment is usually topical or oral carbonic anhydrase inhibitor, for example, dorzolamide 3 times daily and may reduce foveal thickness and improve visual acuity in some patients. Vitrectomy may be required for vitreous hemorrhage or retinal detachment repair, but is technically challenging as retinoschisis cavities are non-progressive. Surgery is not performed purely to flatten these. So basically, vitrectomy is usually done to vitreous hemorrhage and retinal detachment, as because their retinoschisis are non-progressive. Surgery is not performed to flatten these. Gene therapy is under investigation with aim of restoring a normal function of the protein abnormality underlying the retinoschisis. So this is a ERG showing selective decrease in B wave amplitude as compared in the combined response, which is known as electronegative. So negative ERG is present in a case of a retinoschisis. So next is a Stickler syndrome. Stickler syndrome, hereditary ortho-ophthalmopathy, is a genetically heterogeneous disorder of the collagen connective tissue. Inheritance is autosomal dominant STL1 to STL3, autosomal recessive STL4 and STL5 with complete penetrance but variable expressivity. So basically, Stickler syndrome have some collagen disorders, collagen connective tissue disorders. So that is why the bones are also affected and the eyes are also affected. So there are two types: autosomal dominant and autosomal recessive. The autosomal recessive further consists of the three types STL1 to 3, whereas autosomal recessive consists of STL4 to 5. Stickler syndrome is the most common inherited cause of the retinal detachment in children. In general, the prognosis has been poor but may improving with the elevated standards of care. Stickler syndrome type 1, STL1 membranous vitreous type, is the most common form and is the result of the mutation in the COL2A1 gene, which encodes type 2 procollagen. So STL1 basically have a genetic mutation in the COL2A1 gene and which encodes type 2 procollagen. The classic ocular and systemic features are present as occasionally described by Stickler, though there is also a solely or predominantly ocular form of STL1. So both the classic ocular and systemic features are present in STL1. STL2 is a beaded vitreous type, is caused by the mutation in the COL11A1 gene. So it is 2, it is 11. Patient have congenital non-progressive high myopia. So very important, the myopia is high but it is usually non-progressive. There is a sensory neural deafness and other features of the Stickler syndrome type 1. So this is a STL3 is a non-ocular type which is mutation in the COL11A2 gene. Affected individuals have typical systemic features but no ocular manifestation. STL4 and 5 autosomal recessive are extremely rare. Systemic features include midfacial hypoplasia, Pey-Robin features, micrognathia, cleft palate and glossotosis, backward displacement of tongue. So there will be like a midfacial hypoplasia, there can be micrognathia, cleft palate and backward displacement of the tongue. Bifid mild spondyloepiphyseal dysplasia, joint hypermobility, and early onset osteoarthritis. Deafness may be sensorineural or caused by the recurrent otitis media. So this is a Stickler syndrome. A is showing us a facial appearance. B is showing us a cleft and high arched palate. So how do you diagnose the case of the Stickler syndrome? The three characteristic ocular features are high myopia, vitreoretinal degeneration with extremely high rate of retinal detachment, and cataract. So most of the time it's three triad: retinal detachment, high myopia, and the cataract. In STL1, patient exhibit an optically empty vitreous, a retrolenticular membrane, and circumferential um, equatorial membrane that extend in a short way into the vitreous cavity. So STL1 has a membranous was a membranous type, and it is basically have an empty vitreous. So vitreous is empty. There is a membrane which is present in the beneath the lens, which is a retrolenticular membrane, and there is a circumferential equatorial membrane that is extended into a short way into the vitreous cavity. So let's see figure 15.44a is showing us an optically empty vitreous. So you can see there is a highlight membrane, and there is a membrane that is extending into the vitreous. So this is vitreous appearance. B is showing slit lamp in type 1, 360-degree giant retinal tear. So this is a vitreous veil. In STL2 patient, the vitreous has a fibrillary and beaded appearance. So beaded type was type 2. Radial lattice like degeneration associated with RPE, hyperplasia, vascular sheathing, and sclerosis. So retinal lattice degeneration can also be present. Retinal detachment develop in approximately 50% in the first decade of life, often as a result of multiple or giant tears that may involve both eyes. So RD occur in first decade with multiple or giant tears. The pre-senile cataract characterized by frequently non-progressive peripheral cortical wedge-shaped fleck or lamellar opacity is common. So pre-senile cataract can also be present, which is a non-progressive peripheral cortical wedge-shaped fleck. Ectopia lentis can occur but is uncommon. Glaucoma 5 to 10% is associated with congenital angle anomaly. So treatment consists of prophylactic 360-degree laser, retinal laser, or cryotherapy may reduce the incidence of retinal detachment. Regular screening with prophylactic treatment of retinal breaks is essential. So you can do prophylactic 360-degree laser in a case of a high myopia to prevent the incidence of the retinal detachment. And you can do regular screening with prophylactic treatment of retinal break. Long-term review of all the patient is mandatory. Retinal detachment repair is challenging and vitrectomy is generally indicated. Proliferative vitreoretinopathy is particularly common. Complication of redetachment may occur. Cataract in Stickler is often visually inconsequential, particularly when early. If surgery is required, a careful pre-operative retinal evaluation with treatment of break should be performed. Vitreous loss and post-operative retinal detachment are relatively common. So if you are planning to do the cataract surgery in a case of a Stickler syndrome, you first treat the retina before going for surgery. Glaucoma treatment may be required if early onset and presumably related to angle anomaly. Management is generally asked for congenital glaucoma. So then there is a Wegener syndrome, which is a VCAN related vitreoretinopathy, is a rare condition having some features in common with the Stickler syndrome, but no association with systemic abnormality. Excessive vitreoretinopathy is now known to be the same disorder. Inheritance is autosomal dominant, and the mutation in the gene VCAN can be responsible. So Wegener is having a mutation in the VCAN gene. Severity is variable with up to 50% developing retinal detachment often before the age of 15. So what are the signs? Patients tend to have a low to moderate myopia. So myopia which is low to moderate. The key abnormality finding is an optically empty vitreous cavity lacking structural element, and it is thought that this lead to a reduced scaffolding support for the retina. The peripheral retinal vasculature is deficient. So there will be the optically empty vitreous, and it is due to the reduced scaffolding support leads to the reduced support to the retina. And the peripheral retinal vasculature is deficient. Grayish white avascular strand with membrane extend into the vitreous cavity, and there may be circumferential ridge like condensation of the gel at or anterior to the periphery. So because the vitreous is being empty, so there will be the membranes that will be extending into the vitreous cavities. They may be circumferential ridge like condensation of gel or anterior to the retina periphery. So let's see figure 15.45 is showing us a Wegener syndrome. A is showing vitreous appearance. B is showing peripheral chorioretinal atrophy and preretinal membrane. So you can see there is a preretinal membrane. C is showing progressive chorioretinal atrophy, and D is showing FA gross loss of the choriocapillaries. Peripheral retinal changes include progressive chorioretinal atrophy occur, and ectopia is commonly troublesome. The visual field gradually constricts. Cataract is common in younger adults, and glaucoma can develop. Investigation: FA show non-perfusion due to choriocapillary loss. The ERG may initially be normal but later show a reduction of a scotopic B wave amplitude and diffuse rod cone loss. So, fluorescent angiography will show non-perfusion of choriocapillaries, and in ERG may be normal but later shows the reduction in the B wave amplitude and a diffuse cord rod loss. Treatment: retinal breaks and detachments are treated as they occur, but extensive prophylaxis is avoided. Next is a familial exudative vitreoretinopathy. Familial exudative vitreoretinopathy or Crispek-Scapin syndrome is slowly progressive condition characterized by the failure of the vascularization of the temporal retina periphery, similar to that of the seen in the retinopathy of prematurity. So basically there is because the temporal retina vasculature is being formed after at birth or 1 month after the birth. So there is a problem in the vascularization, failure of vascularization of the temporal retina. Inheritance is autosomal dominant, but this is a hereditary condition and rarely X-linked recessive or autosomal recessive with high penetrance and variable expressivity. 4 genes in a common pathway have been implicated. Presentation is with childhood. The prognosis is frequently poor, especially with early or aggressive onset. So signs are the high myopia may be present. So there are 5 stages. Stage 1 is a peripheral avascularity. There is an abrupt termination of the retinal vessels at the temporal equator. Vitreous degeneration and peripheral vitreoretinal attachments are associated with areas of white without pressure. Vascular straightening may occur. So stage 1 consists of the sudden abruption or termination of the retinal vessels at the temporal equator. Next is a stage 2 consists of the peripheral vascular tortuosity and telangiectasias progresses to preretinal fibrovascular proliferation with or without subretinal exudation. So stage 2 consists of the peripheral retinal vascular tortuosity, which leads to the preretinal fibrovascular proliferation. Stage 3 consists of a tractional and the metagenous macular sparing retinal detachment with and without exudation. So there is a retinal detachment but without the macular involvement. Stage 4 and 5 are macular involving and a total retinal detachment respectively. So stage 4 is a macular involving retinal detachment and stage 5 is a total retinal detachment. Vitreous hemorrhage, cataract and neovascular glaucoma can occur. Investigation: wide field fluorescent angiography is invaluable in confirming the diagnosis, ensuring accurate targeting and completeness of the ablation of the avascular retina and identifying asymptomatic cases with subtle features. So fluorescent angiography is usually invaluable in confirming the diagnosis, and it can also ensure the accurate targeting and complete ablation of the avascular retina. Treatment involved retinal should be screened. Lifelong monitoring is required. Laser ablation of the avascular retina is recommended usually once the neovascularization has occurred. So you can ablate the avascular retina. Vitrectomy for retinal detachment is challenging but often successful. Intravitreal anti-VEGF treatment can be useful as a temporizing measure. So this is a figure 15.47. Wild field FA show vascular straightening and abrupt termination with leaking capillaries in the familial exudative vitreoretinopathy. There is an enhanced S-cone syndrome and Goldman-Favre syndrome. So the human retina has three cone photoreceptor types: short wave sensitivity S, middle wave sensitivity M, and long wave sensitivity L. Most inherited retinal dystrophy exhibit progressive attenuation of the rod and all classes of the cone. So because we have a three types of cone photoreceptor S, M, L. So S consists of the short wave, M consists of middle wave sensitivity, and L consists of a long wave sensitivity. And most inherited retinal dystrophy exhibit progressive attenuation of rods and all classes of cone. However, enhanced S-cone syndrome is characterized by the hyperfunction of S-cone and severe impairment of the M and L cone with non-recordable rod function. So basically, enhanced S-cone syndrome is having a S cones are hyperfunction, whereas M and L are severe impairment, and there is a non-recordable rod function. Goldman-Favre syndrome represents a severe variant. Inherited is autosomal recessive with variable expressivity. The gene implicated is NR2E3, which encodes for the ligand dependent transcription factor. So, autosomal recessive inheritance, and gene implicated is NR2E3. Presentation is with nyctalopia in childhood and sometimes hemarolopia. So, there is a night blindness and reduced vision in bright light. Pigmentary changes along the vascular arcade or mid-periphery may be associated with more advanced cases with round pigment clumps. Macular changes may include cystoid maculopathy without fluorescein leakage and schisis. So, the macular changes consist of the cystoid maculopathy and schisis. Vitreous degeneration and peripheral retinoschisis can occur. The prognosis for central and peripheral vision is poor in many patients, particularly by late middle age, and there is no treatment other than supportive measures. So let's see figure 15.48 show an enhanced S-cone and Goldman-Favre syndrome. Severe pigment clumps can be seen and B's during macular schisis and pigmentary changes along the arcade. Next is a snowflake mature retinal degeneration. This rare autosomal dominant condition, gene KCNG13, has some similarities to Wegener syndrome. Retinal detachment is less common and the prognosis is usually good. So, snowflake vitreoretinal degeneration is autosomal dominant and gene associated is with the KCNG13, which has a similar association to the Wegener syndrome. Retinal detachment is less common and prognosis is good. So it has certain stages. So stage 1 shows an extensive areas of white without pressure in the patient, typically under the age of 15 years. So this is a stage 1, which is basically showing the white area without pressure under the age of 15 years. Stage 2 consists of snowflake like yellowish white crystalline deposit in the areas of white with pressure in a patient between age 15 to 25. So there is a snowflake like deposits in the area of white with pressure and their age between age 15 to 25. Stage 3 consists of the manifest with vascular sheathing. So there is a vascular sheathing and pigmentation posterior to the areas of the snowflake degeneration in the patient between 25 to 50 years of age. Stage 4 is characterized by the increased pigmentation, cross-vascular attenuation, areas of chorioretinal atrophy, and less prominent snowflake in a patient over the age of 60 years. The macula remain normal. So stage 4 is basically at the age of 60 years and there is an increased pigmentation, vascular attenuation, and areas of chorioretinal atrophy. Other possible features include mild myopia, vitreous fibrillary degeneration, and liquefaction. So the myopia will be mild, there will be the vitreous degeneration and liquefaction, and a waxy optic nerve head, corneal guttae, and retinal detachment and early onset cataract. Investigation: the ERG shows a low scotopic B wave amplitude. Then there is an autosomal dominant neovascular inflammatory vitreoretinopathy. A rare but interesting inherited gene CAP N5 disorder, autosomal dominant Neovascular inflammatory vitreoretinopathy features panuveitis often onset in the early childhood. So there is a autosomal dominant, mean the inheritance is autosomal dominant. There is a neovascular inflammatory vitreoretinopathy, so it presents as a panuveitis. The initial symptoms is typically due to vitritis with the development of peripheral vascular closure with peripheral and then disc neovascularization. There fundus pigmentation, epiretinal and subretinal fibrovascular membrane. So there will be the vascular closure and then there is a vascularization of the disc. They're going to be the fundus pigmentation, epiretinal and subretinal fibrocellular membrane. Complications include vitreous hemorrhage, fractional retinal detachment. There can be CMO, cataract, and neovascular glaucoma. The ERG shows a selective loss of a B wave amplitude. The prognosis can be poor. Peripheral retinal photocoagulation and vitreous surgery may be required. Autosomal dominant retinochoroidopathy, autosomal dominant retinochoroidopathy, 8 Wirk, is caused by the BEST1 mutation. So presentation is in an adult life if asymptomatic, but frequent discovery is by chance. Vitreous cells and fibrillary degeneration develop, and with non-progressive and very slowly progressive encircling band of a pigmentary disturbance between the ora serrata and equator with the discrete posterior border. Within a band, there can be arteriolar attenuation, neovascularization, punctate phytopaths, and later chorioretinal atrophy. So there is a band of a pigmentary abnormality between the ora serrata and equator, and within that band there can be arteriolar attenuation, there can be neovascularization, there can be punctate phytopacity and chorioretinal atrophy. Complications are not common but include CMO, vitreous hemorrhage, and cataract. Microcordia and narrowophthalmos has been described in some patients. The full field ERG is subnormal in older patients. Only the prognosis is good. Then there is a nice dysplasia. Nice dysplasia is usually caused by defect in the type 2 collagen gene COL2A1, which is also involved in the Stickler syndrome type 1. Inheritance is autosomal dominant, but in most cases will present a fresh mutation. High myopia, vitreous degeneration, and retinal detachment and ectopia lentis can occur. Systemic features may include short stature, a round face, and orthopathy. So it is very similar to the Stickler syndrome type 1. So that's it for the part 7. See you in the next lecture.